Test 1 2 1 2. Test test test.
Good afternoon. Thank you for the invitation to present to you today. My name is Rathi Pillai. I'm a medical oncologist from Emory University, and I actually specialize in the treatment of lung cancer. Just out of curiosity, any oncologists or folks that work with oncology patients in the audience? All right, cool. Well, this is going to be talking about some of the new treatment developments in lung cancer, and this is probably going to be a little bit specific and a little bit over your head, so feel free to stop me at any point to try and explain what I'm talking about. In terms of disclosures, I have received research funding from Bristol Myers Squibb, and I've served as a consultant for AstraZeneca. One important aspect of this presentation is actually participating in the questions that we ask with your audience response system. You actually have little keypads at your seats, and with every question, if you could just vote for an answer, even if you have no idea what I'm talking about, just put in your favorite letter, and then we'll talk a little bit more about what the questions are about, and hopefully you'll have some better understanding when we re-expose you to those same questions at the end. So just to start with an easy one, what is your profession? Okay, great. Oops, sorry. So it looks like there's a good mix of healthcare professionals. Almost a third of you are nurses and a quarter physicians. Okay, what is your practice setting? Okay, this is a community hospital. And here are some of the questions. Second-line therapy with a PD-1, PD-L1 inhibitor, this is referring to an immune-activating treatment in cancer, is not recommended for a patient with which of the following characteristics? A, age greater than or equal to 75, B, PD-L1 level of 1% or less, heavy smoking history, a patient with brain metastases, or patients who have EGFR mutations. Okay, nice variation in the answers. We are going to review what the best answer would be with some of the data we present in the talk. Which patients in particular benefited from ramucirumab, which is an angiogenesis inhibitor, in the REVEL study? A, patients with an ECOG performance status of 2, B, patients with squamous cell histology of lung cancer, C, patients with shorter time to progression after first-line platinum-based therapy, or D, unsure. Okay. I like the honesty in the audience. Almost half of you are unsure, which is fair at this point. Hopefully not as many say that at the end. And then based on current recommendations, what would be the most appropriate second-line therapy for a 49-year-old patient who is PD-L1 positive with high staining of 55% and metastatic squamous non-small cell lung cancer who is symptomatic and progressed while receiving first-line pembrolizumab? Pembrolizumab is another immunotherapy. A, switch to different immune checkpoint inhibitor. B, continue the same immunotherapy beyond progression. C, platinum-based chemotherapy. D, addition of platinum-based chemotherapy to pembrolizumab. Or E, docetaxel with or without ramucirumab. Okay, most of you thought chemotherapy added to the immunotherapy. What would you recommend for a patient with non-squamous lung cancer and low PD-L1 expression who has progressed 4 months after completing first-line therapy with carboplatin, pemetrexed, and pembrolizumab, a combination of chemo and immunotherapy, while receiving maintenance therapy with pembrolizumab and pemetrexed? A, switch to a different immunotherapy and chemotherapy. B, re-challenge with platinum-based chemo with or without bevacizumab. C, continue pembrolizumab and switch to a different chemotherapy agent. D, docetaxel, which is a completely different chemo with ramucirumab. Or E, docetaxel alone. Okay, most of you went with C. So by way of an introduction, I'm going to be talking about non-small cell lung cancer, and specifically patients who have metastatic or advanced stage non-small cell lung cancer, which is primarily treated with systemic therapy. The systemic therapy choices have expanded very rapidly over the last few years with better understanding of the biology of lung cancer and having better treatment options specific to the lung cancer biology. The first thing that we need to know as oncologists who treat lung cancer is, in terms of non-small cell lung cancer, what histology of lung cancer we have. The majority of patients we see nowadays have adenocarcinoma histology, and about a third will have squamous cell carcinomas. Once we know the histology, patients who have adenocarcinoma histology, or those patients who are light or never smokers, actually will have further testing done on their tumor biopsy specimens to look for driver mutations, which can actually be targeted with targeted therapies that slow down the overactivated cellular signaling that is a result of those driver mutations. And the mutations that we have FDA-approved therapies that work for targets include epidermal growth factor receptor mutations, ALK and ROS1 rearrangements, and BRAF mutations. BRAF mutations are commonly seen in patients with melanoma. For all four of those abnormalities, we have targeted therapy options that work better than chemotherapy. If the patient doesn't have any targetable mutations, we like to check for the level of PD-L1 expression. PD-L1 is a protein that can be detected by immunohistochemistry on a tumor biopsy specimen. Patients who have higher levels of PD-L1 expression tend to be more responsive to immune-activating treatments versus our standard chemotherapies. Patients who have 50% or higher levels of PD-L1 expression in the first-line setting have much improved survival and response rates if they're treated with an immunotherapy agent called pembrolizumab rather than our old standard platinum doublet chemotherapy. And then in patients who've already been exposed to chemotherapy, if the PD-L1 level is 1% or higher, they would be candidates for a specific drug called pembrolizumab. Patients who have higher levels of PD-L1 expression tend to have more benefit from immune-activating treatments, even in second-line or salvage treatments. And so that's why we tend to check PD-L1 levels. This is a summary table of our current treatment landscape in non-small cell lung cancer. On the left are those patients who have driver mutations, and the slide lists all the specific targeted therapies that are available for each of these driver mutations. On the middle and right panels here, we have patients who have non-squamous histology who don't have any mutations, and it lists the first-line treatment options followed by second-line options. And again, those patients who have high levels of PD-L1 expression are candidates for first-line immunotherapy with pembrolizumab. The same is true for a patient with squamous histology and high PD-L1 expression. Conversely, if the patients don't have the high 50% or higher levels of PD-L1 expression, our current FDA-approved therapies would include a combination of chemotherapy and pembrolizumab in patients with non-squamous histology, or just chemotherapy alone, and that tends to be carboplatin or cisplatin with a second drug specific to the lung cancer histology. As of right now, there is not an approved combination of chemo and immunotherapy in squamous patients, although I suspect that will be changing soon. After patients progress on their first-line therapy, we have known for many years that giving patients further treatments can actually prolong their survival and improve their quality of life. Our old standard second-line therapy was a chemotherapy drug called docetaxel, but now with a lot of immunotherapies that are available, patients who have not been exposed to immunotherapy in their first treatment can actually be treated with an immune activating treatment. And you might have seen patients who have had these treatments in the emergency room, in the intensive care unit. You might have seen these immunotherapies advertised on television. There's been a lot of excitement about these immunotherapies in the community. And then finally, in second line and beyond, aside from docetaxel and immunotherapy, we also have the addition of an angiogenesis inhibitor to docetaxel, which has been shown to improve overall survival. So the summary of this slide is that there are many different treatment options, even for a patient with incurable metastatic lung cancer, and an oncologist really needs to know a lot about the patient's lung cancer in order to determine the best possible treatment in the first line setting and then after the patient's been exposed to some treatment. The majority of my talk is going to be focused on what we use for second-line therapy or treatment in a patient who's already been exposed to chemotherapy. And some of the factors that impact the treatment selection for a patient who has disease progression after their initial treatment is actually a lot of it overlaps with some of the things we look at for first-line treatment considerations. So the first two things in a patient that we look at is the patient themselves and then their tumor's biology. In the patient, what's very important to us as oncologists is how functional the patient is or what their performance status is. Somebody who's bedbound is not going to be able to tolerate treatment and would not benefit from taking systemic chemotherapy or even some of our other treatments. The patient's age and comorbidities is also, are both also very important factors in the decision for what treatment is the best. In terms of the tumor, we brushed upon some of these factors, the histology of the tumor, if the patient has any mutations that could be targeted, and then we also look now at PD-L1 expression and sometimes consider the patient's clinical tumor burden. And then finally, in a patient who has already been treated, obviously we need to know what kind of treatment they've been exposed to before, how they did with those treatments, and what kinds of side effects the patients had from their first treatment, which may impact how they tolerate their next treatment. We have used second-line chemotherapy dating back almost 20 years now. We have known about the survival benefits in patients who are continued on some aspect or some form of chemotherapy in the metastatic setting. Our first salvage chemotherapy that was approved was actually tested back in 2000, and this is a drug called docetaxel. It's a microtubule inhibitor, and it was compared to just best supportive care. And you can see that there is a nice extension of the overall survival curve with the use of docetaxel. And just a note in your mind to remember, the median overall survival that we typically see with docetaxel is usually anywhere between 8 to 9 months. Similarly, another chemotherapy drug called pemetrexed was also tested in patients who had already been exposed to chemotherapy, and it also showed a survival benefit when compared to our old standard of docetaxel. The patients who have non-squamous histology are those who actually benefit from pemetrexed, and having a squamous histology is a contraindication to using pemetrexed as a treatment option in the salvage setting or in initial lines of therapy. And then finally, more recently in the salvage setting, there was a study looking at patients who have squamous cell lung cancer and using EGFR inhibitors or epidermal growth factor receptor inhibitors, which are oral drugs that can have some activity in patients who don't have the specific mutation for epidermal growth factor receptor. And in the LUX-Lung-8 study, patients with squamous cell lung cancer who had already progressed on prior treatment were randomized to either afatinib or erlotinib, both of which are EGFR inhibitors. Afatinib is an irreversible inhibitor of EGFR signaling, and there was a mild increase in progression-free survival with the use of afatinib and an improvement in median overall survival from 6.8 months with erlotinib to 7.9 months with afatinib. And based on this data, the FDA has included afatinib as an option for patients with squamous lung cancer who have progressed on prior chemotherapy. One important development in oncology that was all the rage about 10 or 15 years ago was the introduction of drugs that actually work by preventing the growth of new blood vessels to tumors. Cancers or tumors require blood vessel supplies to the tumors in order to bring oxygen and nutrients to enable the tumor to continue growing. So if you cut off the tumor's blood supply, you're essentially cutting off its lifeline to be able to grow and metastasize. And there have been a few angiogenesis inhibitors that have been developed and studied in lung cancer. Bevacizumab is a drug that is a monoclonal antibody that targets the VEGF, or vascular endothelial growth factor, ligand, and this has been approved in the first-line therapy of non-small cell lung cancer in combination with chemotherapy. Bevacizumab has been studied in second-line therapy, and two other drugs that have been studied in second-line therapy are ramucirumab, which is a monoclonal antibody against one of the vascular endothelial growth factor receptors itself, the VEGFR2, and then there's a targeted, a tyrosine kinase inhibitor called nintedanib, which is a small molecule inhibitor of intracellular signaling in the vascular epithelial growth factor receptor pathway. This table summarizes the use of angiogenesis inhibitors in patients who have lung cancer and who are receiving treatment in the second-line setting. The three studies reviewed here are REVEL, which looked at the combination of ramucirumab and docetaxel, LUME-1, which looked at the combination of nintedanib with docetaxel versus docetaxel alone, and then finally the ULTIMATE study, which combined weekly chemotherapy with bevacizumab versus docetaxel alone. And the table shows us that all three angiogenesis inhibitors in combination with chemotherapy resulted in increases in progression-free survival, which were statistically significant. However, only the use of ramucirumab in combination with chemotherapy led to a statistically significant improvement in overall survival. And therefore, that is the only angiogenesis inhibitor that we have available to use in patients in second-line or beyond treatment. This is the REVEL study that showed that survival benefit of ramucirumab when added to docetaxel. This study randomized patients who had progressed on platinum-based chemotherapy and had metastatic disease and randomized them to either docetaxel with a placebo or docetaxel with ramucirumab. Ramucirumab is given on an every 3-week schedule with docetaxel, and both are IV agents. The patients were allowed to continue on treatment until disease progression, unacceptable toxicity, or withdrawal. And what we see here on the right is the overall survival curve from the trial, which shows a 1.5-month improvement in median overall survival with the addition of the angiogenesis inhibitor ramucirumab. The hazard ratio here was 0.86, and this was statistically significant. What was interesting in this study is that we actually saw a survival benefit in both non-squamous and squamous histologies of lung cancer. Previously, patients who had squamous histology were not candidates for angiogenesis inhibitors, at least in the first-line setting. And we had a nice improvement in overall response rate, up to 23% with the use of ramucirumab. And importantly, adding ramucirumab to docetaxel did not have any detrimental effect on quality of life. An interesting subgroup analysis which came out a few years ago looked at the impact of the time to progression with the patient's first-line treatment and the impact of the benefit of the addition of ramucirumab to docetaxel in the patient's next treatment. TTP is time to progression, and looking at patients who had very rapid time to progression with their initial chemotherapy of 9 weeks or less, these patients actually had the highest impact of the addition of ramucirumab to their regimen. The median overall survival increased from 4.8 months to 8.3 months, and the reduction in the risk of death was actually 41%. The improvement in survival was also seen in patients who had a longer time to progression, but the hazard ratio of survival improvement was not as marked as in those patients who had very rapid time to disease progression. So this suggests in patients who have very rapidly progressing disease, who progress quickly on their first chemotherapy, those are the ones that are perhaps most likely to benefit from adding ramucirumab to your standard docetaxel in the second-line setting. And we now have many more options for salvage therapy with the approval of immunotherapy. Immunotherapy in lung cancer and in oncology as a whole has been a paradigm shift in our treatment. And basically what these drugs do is they overcome T cell inhibition that is caused by the cancer itself. So when we give patients these drugs, they're all intravenously administered monoclonal antibodies. What happens is we're trying to reactivate patients' T cells to actually attack their cancer cells. And we've had some really amazing success stories with this type of strategy. This table summarizes the key trials using these immunotherapies or checkpoint inhibitors in advanced non-small cell lung cancer. And we have some recent FDA approvals that have come out based on new trials that have been presented in the last year. In terms of FDA-approved therapies, on the right in green, you can see that chemotherapy with pembrolizumab is something that recently got approved by the FDA in patients who have non-squamous non-small cell lung cancer. And we have also the ability to use immunotherapy by itself, which is superior to chemotherapy in patients who have PD-L1 high expression. We had recent data that looked at the use of pembrolizumab or immunotherapy in patients who have only 1% or higher PD-L1 expression that did show a modest improvement in overall survival, and this is being reviewed by the Food and Drug Administration. And then further, we have had some new data looking at chemotherapy and immunotherapy combinations with taxanes. And then finally, chemotherapy, immunotherapy, and angiogenesis inhibition as another study. These last 3 trials have not yet been approved by the FDA. And then finally, the CheckMate 227 study looked at the use of 2 immunotherapy drugs, nivolumab and ipilimumab, which are currently approved in patients who have metastatic melanoma, and looking at these 2 drugs in combination in patients who have metastatic lung cancer. And what was interesting is we have found a new potential biomarker, which is tumor mutation burden, that might predict patients most likely to benefit from this double immune activating strategy. This is not yet FDA approved. This slide summarizes the 4 big trials that led to the approval of 3 different immunotherapy drugs in the second-line setting in patients with metastatic lung cancer that had progressed on prior chemotherapy. The study designs were all similar. What the studies involved were patients who progressed on first-line therapy, were randomized to either immunotherapy or our salvage chemotherapy, docetaxel, which was our standard second-line treatment up until these trials came out. The 3 drugs that were studied here were nivolumab and pembrolizumab, both of which inhibit PD-1. And atezolizumab is a 3rd drug that inhibits the ligand of this inhibitory signaling pathway, PD-L1. And all 4 studies showed consistently that immunotherapy was superior to docetaxel chemotherapy in the second-line setting. And we saw that the median survivals improved, and the rates of 2-year overall survival in patients with metastatic lung cancer improved from the 10 to 20% that we were seeing with chemotherapy involving docetaxel to now almost 25% to close to 35% 2-year survival rates, which is quite remarkable. Based on this data, all 3 drugs have been approved in patients who have already been treated with chemotherapy. There are some clinical selection factors that may predict which patients are most likely to benefit from these immune-activating drugs. One thing that has been studied is looking at the patient's smoking history. And in 2 different analyses, we've seen that patients who are current or former smokers have higher response rates than those patients who never smoked. And you can see that here in this table as well from another study, that the survival benefit was mainly seen in current and former smokers treated with nivolumab in the CheckMate 057 study, and the never smokers really didn't have a survival benefit when looking at nivolumab versus docetaxel. One potential mechanism for why this might be the case is that patients that are smokers have a lot more DNA damage because they're exposed to carcinogens. And because of that DNA damage, they have high levels of mutations, and their tumors are very different looking than their regular normal healthy cells. And so the immune system is much more likely to react to those very mutated cancer cells compared to those patients who never smoked, whose cancers don't have very many mutations. We have also had some studies looking at age and performance status as factors in selecting patients that could be treated with immunotherapy. This study of nivolumab in the second-line setting showed that patients who were 70 years or older had similar survival benefit as all patients who were treated in the study. But interestingly, those patients who didn't have as good of a functional status, which is what ECOG performance status 2 means, did not have a very robust survival benefit when treated with nivolumab. So this study suggests that immunotherapy can still be effective in elderly patients, but in patients who have a poor performance status, they don't tend to have as much of a benefit. And then another biomarker that has been looked at in selecting patients that could be treated with immunotherapy is looking for the presence of targetable mutations. Patients who have EGFR mutations are usually treated with EGFR targeted therapies, but a small number of patients who have EGFR mutations who progressed on their targeted therapy were included in these studies that looked at immunotherapy versus chemo. And interestingly, the patients who have mutations in EGFR actually really do not have much of a survival benefit with immunotherapy versus docetaxel, as depicted in this meta-analysis on the forest plot. And so because of this, we tend to avoid using immunotherapy in patients who have EGFR mutations or who have targetable mutated cancers. And again, the proposed mechanism for why this might be the case is relating back to the immunogenicity of the cancer. Many patients who have EGFR mutations are never or very light smokers, and so similarly to those never smokers who didn't benefit from immunotherapy, it's thought that these EGFR mutated lung cancers have very low mutation burdens and therefore are not as immunogenic and are not as likely to benefit from the immune system being activated against the cancer. There are different assays or tests that can be used to look at the expression of PD-L1, the ligand which is expressed on the surface of tumor cells, that have been studied with each of these 3 different drugs. And the one that we're currently commonly using is the 22C3 assay, mainly because it is linked to our ability to use pembrolizumab in patients who have the highest levels of PD-L1 expression in the first-line setting. All three immunotherapies are looking at PD-L1 expression by immunohistochemistry tests. And most of these assays are looking at the levels of PD-L1 expression in the tumor cells. One of the assays looks at the expression in the tumor cells as well as the immune cells in the tumor microenvironment. And there are different cutoffs that are used in terms of defining what is positive with each of these assays. So this has created a little bit of confusion within the oncology community because each different drug uses a different test to test for PD-L1 expression, and what does that mean? Do all of these tests have similar results? Do we need to use one test over others because one test is better than the others? And one of the things that have been done to look at the differences in the tests using these immunohistochemistry assays was to actually compare what positive was with each of these 4 different antibody tests and see if positive was the same in one tumor specimen tested with all 4 of these different immunohistochemistry assays. And what this blueprint study did was comparing all of these 4 assays, and they found that 3 of the 4 immunohistochemistry assays looking for PD-L1 expression actually were pretty similar in calling a patient's tumor positive. There was only one assay, which is the SP142 assay, that was an outlier that didn't match the positive results of the other tests. There have been some clinical evaluations of the differences in the PD-L1 assays and if they impact a patient's benefit from immunotherapy. This study actually looked at atezolizumab versus docetaxel, which is the OAK study, and these are 2 different analyses of survival endpoints in patients who have high levels of PD-L1 expression, either with the SP142 assay or the 22C3 assay. And the patients who received immunotherapy or atezolizumab are depicted in blue, and the chemotherapy is in red. And what you can see is that in both assays where we have positivity, there's a really nice separation of survival seen with the patients who receive immunotherapy and have high levels of PD-L1 expression. Similarly, in the patients who have PD-L1 negative tumors, which are seen with these 2 different PD-L1 assays, there still is a survival benefit seen with the immunotherapy, but it's not as big or as robust of a survival benefit. So the conclusion of this retrospective analysis is that each of these 2 immunohistochemistry assays can identify cohorts with the likelihood of improved overall survival in patients who have high levels of PD-L1 expression. And then another biomarker that's been investigated to predict patients that would benefit from immunotherapy is something called tumor mutation burden. Essentially, tumor mutation burden is just a measurement of the number of mutations that a cancer has. And patients who have high levels of mutations have higher tumor mutation burdens, and these tumors are thought to be more immunogenic to the immune system. This analysis was looking at nivolumab versus chemotherapy in patients who were newly diagnosed with lung cancer. And in patients who have high tumor mutation burden, the median progression-free survival was improved with the treatment of nivolumab to 9.7 months from just 6 months with chemotherapy. Conversely, in patients who had lower medium tumor mutation burden, they actually had a lower progression-free survival when they were treated with nivolumab instead of chemotherapy. And the hazard ratio here was 1.82. So this retrospective analysis suggests that tumor mutation burden may be able to predict patients who would actually benefit from receiving immunotherapy with nivolumab in the first-line setting. In a further analysis, the investigators actually combined looking at high tumor mutation burden and high levels of PD-L1 expression, which are 2 different tests done on the same tumors. And the patients who had the highest progression-free benefit with using nivolumab were those patients who had high tumor mutation burden and very high levels of PD-L1 expression. Interestingly, the patients who had high PD-L1 expression but did not have a high tumor mutation burden really did not seem to have much of a benefit to being treated with nivolumab. So this is something that hasn't really been adapted in clinical use yet, but is being investigated very closely in different studies. And then finally, tumor mutation burden might be a way of selecting patients who would be candidates for treatment with two immunotherapies combined, the nivolumab and ipilimumab. The CheckMate 227 study was a complicated study that looked at nivolumab, which is an immunotherapy, combined with chemotherapy or with another immune activating agent, ipilimumab, in patients who have metastatic lung cancer. And what we see is on the left, the patients who have high tumor mutation burden, defined as greater than or equal to 10 mutations per megabyte, and low PD-L1 expression, the patients who have the best survival outcomes in terms of progression-free survival are those who are treated with double immunotherapy, nivo and ipi. Patients who receive chemotherapy who have high tumor mutation burden did not have as long of a progression-free survival. Conversely, in patients who have low tumor mutation burden and low PD-L1 expression, the outcomes are pretty equivalent whether you give chemotherapy or immunotherapy with chemo or two immune activating agents. So the conclusion of this analysis is that patients who have low tumor mutation burden and low PD-L1 expression probably could just be treated with chemotherapy, as they don't have much of a benefit to treatment with an immune activating drug. And then this was an analysis of tumor mutation burden measured by circulating tumor DNA. We actually have the ability to get blood samples from cancer patients, and we can look at tumor DNA and measure levels of mutations, and actually even identify driver mutations from a blood sample, which is really amazing. So this was a retrospective analysis looking at the blood measurement of tumor mutation burden and the efficacy of immunotherapy in the salvage setting. And in the patients who had high levels of tumor mutation burden, they had a significant improvement in progression-free survival when they were treated with atezolizumab, but that progression-free survival benefit was lost in the patients who had low tumor mutation burden. So this is a retrospective analysis, again, something we're not currently using in clinic, but we are awaiting the results of prospective studies to validate the use of tumor mutation burden as a predictive biomarker. One thing that's interesting with the use of immunotherapy in lung cancer is that we can see very different response patterns. Commonly, when we look at a patient who's receiving a treatment in the oncology clinic, what we do is we get a baseline scan, and after the patient has been on the treatment for 2 or 3 treatments, we'll get another scan, and we compare the tumor measurements on the new scan with the baseline scan. And typically, if the patient has significant growth, which is defined as 20% or higher, some of the diameters of all the tumors on the new scan, that's defined as disease progression. And with chemotherapy, if we see growth on the scans, that pretty much tells us that the chemotherapy is not working and we should change to something different to see if we can have better control over the cancer. With immune treatments in the early studies, particularly in melanoma, there were patients who would have growth seen on their scans, but clinically they were still doing really well. They didn't seem like their cancer was getting worse. And so these very brave investigators said, let's just keep you on the immune treatment and see what happens. And in some of those melanoma patients, the next scan actually showed that the tumor would regress. And what was thought to happen here is that the tumors looked bigger because there was immune cell infiltration in the tumor, and that looked like the tumor was actually bigger when we looked on the CT scan. And then with the immune system being activated and being allowed to continue to attack the tumor actually shrunk when we looked at it again on a subsequent scan. That's called pseudoprogression. And this is something that has been looked at in lung cancer. It's not a very common entity that we see in lung cancer. One interesting thing in realizing that there is a possibility that progression on radiologic imaging may actually be just immune cell infiltration on tumors has been that when we see larger tumors on our scans as oncologists in patients who are receiving immunotherapy, if the patient is clinically stable, we'll just keep them on the same immunotherapy and see if we can find a patient who's actually a pseudoprogressor. And this was actually a retrospective analysis of looking at patients who received second-line immunotherapy atezolizumab, and when they were found to have disease progression on scans, to actually continue them on the same immunotherapy on atezolizumab beyond their progression. And what was interesting in this retrospective analysis is the patients who continued on the immunotherapy after disease progression on scans actually had an improved overall survival compared to those patients who were switched to a different treatment, which is seen here in the middle, 8.8 months, versus those patients who didn't get any other treatment who had the worst survival outcomes. So this retrospective analysis suggests that even in patients who have disease progression, there could be a survival benefit to continuing immunotherapy after the time of progression on scans. This is a retrospective analysis and definitely will need prospective validation to have a stronger impact on clinical care. Alternatively, we do know about this other entity called hyperprogression, in that there are some lung cancer patients who, when they receive an immune activating treatment, actually have their cancers blow up or grow very rapidly. And we see this hyperprogression in about 14% of patients who receive immunotherapy, as depicted in this retrospective analysis seen here. And in patients who are hyperprogressors or HPD, they have very poor survival outcomes. Patients who had hyperprogressive disease had a median survival of only 3.4 months versus patients in the overall cohort of patients receiving immunotherapy who had an overall survival of 13 months. So we don't have a way of identifying which patients are going to be hyperprogressors, but that is something that is being investigated to see if we can figure out how to avoid creating this problem in our lung cancer patients. And one thing I wanted to mention to you is that immunotherapies have very unique toxicities compared to chemotherapy. Chemotherapy that you're used to seeing our patients receive causes cytopenias, increased risk of infection, nausea, and vomiting. And because of the very different mechanism of action with immunotherapy, we actually don't see those toxicities with these immune activating drugs. The most common toxicities we see with immunotherapies are fatigue, diarrhea, poor appetite, and skin rashes. However, there are some patients who develop autoimmune toxicities where their immune systems are overly activated by the immunotherapy, and we start getting immune damage of normal, healthy tissues. These don't tend to happen very often, but they can occur in any organ system, and so we closely monitor patients for the development of these immune-related adverse events. The most common of them are aberrations in thyroid function, so we routinely monitor TSH in these patients. And some of the very rare ones that have been fatal in lung cancer patients have been the development of an autoimmune pneumonitis. If a patient develops an immune-related adverse event, it's typically treated by stopping the immunotherapy and then giving the patient high-dose steroids. So you might see one of our patients in the emergency room on the floor who develops one of these immune-related adverse events, and typically that's how we manage them, is by giving steroids. So there have been a lot of changes in our management of lung cancer because we have more data that is showing that using immune activating treatment as an initial treatment strategy is actually beneficial in patients who have metastatic disease. Our first study that showed this was the KEYNOTE-024 study, which looked at pembrolizumab, a PD-1 inhibitor, versus platinum doublet chemotherapy in patients with newly diagnosed metastatic lung cancer. And in patients who were selected by PD-L1 status, 50% or higher, there was a very impressive improvement in overall survival. With our latest update of the study, the median overall survival of patients who received immunotherapy was actually 30 months versus patients who were treated with chemotherapy who had a median overall survival of 14 months. So just imagine a patient with metastatic lung cancer, which is a death sentence, they can live over 2 years with immunotherapy as seen in this study. That's amazing to us who treat lung cancer patients. At ASCO, our annual oncology meeting this year, a study was presented to see if that survival benefit with initial treatment with immunotherapy is seen in patients who have only 1% or higher PD-L1 expression. And this was the KEYNOTE-042 study. The study was the same design with chemotherapy administered versus immunotherapy, and the primary endpoint of the study was overall survival. Looking at the different cutoffs of PD-L1 expression and the survival curves at the bottom, the patients who had the highest levels of PD-L1 expression, 50% or higher, had the most survival improvement, but there was a survival improvement even seen in patients who had 1% or higher. The decrease in risk of death was 19% if they received pembrolizumab instead of chemotherapy. So this is something that is being reviewed by the FDA to see if that could be a potential treatment option for patients who have only 1% or higher expressions of PD-L1. And another strategy that has developed is combining chemotherapy with immunotherapy to actually improve outcomes. And this is a study looking at a combination of chemotherapy with immunotherapy in patients who have non-squamous, non-small cell lung cancer. And what we see with the combination of chemotherapy and immunotherapy is that we have very high rates of response with the triple therapy. That's seen here in the bar graph. Almost 50% response rate is seen with the triple drug strategy versus only 20%, which is typically what we see with chemotherapy alone. And because of this improved response rate, we see improvements in progression-free survival and overall survival. These benefits are actually seen in patients irrespective of the level of PD-L1 expression. And surprisingly, the addition of immunotherapy to chemotherapy doesn't result in a very marked increase in toxicities. This tends to be a pretty well-tolerated strategy. So this is something that we are currently using in our non-squamous, non-small cell lung cancer patients. And let's see. Those are some. So this study was the comparison of chemotherapy with chemo and immunotherapy in patients who have squamous lung cancer. This was presented at ASCO this year, and similarly to what our prior study showed, there was a really good improvement in response rate with the addition of immunotherapy to chemo, and because of that, we saw improvements in survival endpoints. This is not currently an approved strategy in patients with squamous lung cancer, but it is being reviewed by the FDA. And one other potential strategy, we had heard a little bit about tumor angiogenesis being a target of therapy. One potential strategy would be to combine immune activation with inhibition of tumor angiogenesis. And this was thought to be a good strategy because we have actually known for a while that angiogenesis inhibitors can be activating to the immune system. This was a study that was published in the New England Journal of Medicine that looked at the combination of chemo with an angiogenesis inhibitor, bevacizumab, with immunotherapy, atezolizumab. And the basic endpoint of the study was looking at if the addition of atezolizumab to chemo and angiogenesis inhibition results in improved survival outcomes. And there was a modest improvement in progression-free survival, and in early overall survival data, there seems to be an improvement with the combination of bevacizumab and atezolizumab with chemo, although the hazard ratio is not as impressive as what we saw with chemo and immunotherapy alone with the pembrolizumab data. And what was interesting about this 4-drug strategy is that irregardless of PD-L1 expression, and especially the presence of EGFR mutations, this 4-drug strategy seemed to do better than chemo and angiogenesis inhibition alone. And let's see. So based on these new updates, this is our new potential treatment algorithm for patients who have lung cancer with some additions of immunotherapy in the first-line setting. If a patient is exposed to immunotherapy in the first-line setting, we would still use chemotherapy with or without ramucirumab in the second-line setting, just because we have not seen that continuing immunotherapy after patients have disease progression has been beneficial. So I'm just going to run through a couple of cases because I know I'm running over time here. This is a patient who is a 69-year-old gentleman. He's a smoker that quit a while ago, and he presents to the clinic with a worsening cough and dyspnea. He's found to have bilateral pulmonary nodules, pleural effusion, and mediastinal adenopathy, but has no evidence of disease outside of his chest. He has a biopsy of one of the mediastinal nodes, which shows squamous lung cancer. He has a good performance status, and when we looked at his PD-L1 expression, he has low expression of 1%. An interesting aspect of his past medical history is that he actually had an autoimmune disease, psoriatic arthritis, that required treatment with infliximab, and that's currently in remission. So because of that, the oncologist didn't want to give an immunotherapy because the immune treatments can actually reactivate autoimmune disease. So the patient was treated with combination chemotherapy. Unfortunately, had rapid disease progression with only 2 treatments of chemotherapy. So what second-line treatment would you recommend for this patient who has a history of autoimmune disease that now has disease progression that occurred pretty rapidly during his first-line chemotherapy? A, immunotherapy, B, docetaxel, C, docetaxel with ramucirumab, or D, afatinib, the EGFR inhibitor. All right. The majority of you got the answer that I would have selected, which is docetaxel and ramucirumab. Again, we don't want to use immunotherapy in a patient who has a history of autoimmune disease because of the risk of reactivation of the autoimmune disease. And we did see that in patients who had rapid disease progression, 9 weeks or less, that they had the best survival improvement with the use of docetaxel and ramucirumab. So the patient's treated with that combination and responds, but unfortunately goes on to progress in his liver and his bone. He has a pretty good performance status, and he wants to continue on treatment. What would you recommend at this time? A, immunotherapy, B, single-agent chemotherapy that's different from what he's received, C, afatinib, or D, supportive care? All right, kind of a wide range of answers here. Supportive care is always an option for any of our patients. Since he has a pretty good performance status, I would still be willing to continue him on treatment. I would still hesitate to give immunotherapy because I think his psoriatic arthritis would get reactivated by the immunotherapy. So I would probably actually use single-agent chemotherapy. Afatinib is also a potential option based on the Lux Lung 8 study that we reviewed. So in our second case, we're looking at a patient who has a lung adenocarcinoma. This is a 72-year-old female who has a heavy smoking history. She also presents with cough and some fatigue. She has this large right upper lobe hilar mass, which is biopsied and shows an adenocarcinoma. Unfortunately, she has extrathoracic metastases in her bone and liver. She is actually pretty healthy otherwise, has a good performance status. All of her molecular testing is negative, so she does not have any targetable mutations. And when we do her PD-L1 testing, she has low moderate staining with 20%. So based on that, she wasn't a candidate for first-line immunotherapy, and she was treated with platinum doublet chemotherapy. She does well for 4 treatments, and then she has disease progression. She subsequently then started on immunotherapy in the second-line setting, which is our common standard of practice, and she has a near complete response that you can see on the PET scan. Unfortunately, as she's on treatment, she starts developing dyspnea on exertion, gets hospitalized, and on her CT of her chest has evidence of pneumonitis. Because of that, her immunotherapy was stopped. She started treatment with steroids, prednisone 1 milligram per kilogram, and her symptoms improved. She gets out of the hospital, and she slowly tapered off of the steroids. When she gets repeat scans done, she does have evidence of disease progression in her bone and her lung, but the pneumonitis has gone away with the steroid therapy. She still has a good functional status. So what would you recommend in terms of her lung cancer treatment at this point? Would you re-challenge her with the immunotherapy because she responded to the steroids and her pneumonitis has now resolved? Would you give her a different immunotherapy in the hopes that that different immunotherapy wouldn't cause the pneumonitis issue? Or would you switch to chemotherapy with either docetaxel or docetaxel and ramucirumab? All right, kind of all over the box here. I would hesitate to re-challenge a patient with immunotherapy because there is a high likelihood the patient would have recurrent pneumonitis, and sometimes the pneumonitis will not respond to steroids. So typically we wouldn't re-challenge the patient with the same immunotherapy or with a different immunotherapy because the risk of recurrent pneumonitis is still present with a different immunotherapy. So I would go with either C or D as my safest option. And then in a patient who has an EGFR mutation, we have a young woman who's a never smoker who presents with cough, and she is diagnosed with metastatic lung cancer on the basis of a thoracentesis. She was found to have an EGFR mutation, and she has low PD-L1 expression on her tumor. So she was actually treated with targeted therapy, which is called osimertinib, and after she's been on the targeted therapy for a couple of years, she starts developing symptomatic disease progression, but she still has a very good performance status. What would you recommend as the next treatment for this patient? Would you give platinum doublet therapy with or without the angiogenesis inhibitor bevacizumab? B, would you give immunotherapy to an EGFR mutated patient? C, would you give chemo with immunotherapy? D, would you give docetaxel and ramucirumab? Or E, would you re-biopsy for additional molecular profiling to see if the patient could be a candidate for another targeted therapy? Okay, so I would avoid using immunotherapy in a patient who has an EGFR mutation because in our retrospective meta-analysis data, we saw that patients who have EGFR mutations really did not tend to benefit from immunotherapy. I think giving chemotherapy either with or without bevacizumab could be an option, or potentially with immunotherapy and chemotherapy combination. What we typically like to do in these patients with mutations is rebiopsy to see if the patient actually has a new mutation that we could target with targetable treatment. So the patient undergoes a repeat biopsy, but there was no driver mutations that we could treat with targeted therapy. She's treated with chemotherapy, and unfortunately, after 6 months, she then develops disease progression. What would you recommend as her next type of treatment now? Would you give immunotherapy, docetaxel, ramucirumab, another combination of chemotherapy, or taxane monotherapy, which is also chemo? Yeah, we didn't really go over a lot of this stuff here. So the main point of this is I still would avoid using immunotherapy. I would say that the best option would be docetaxel and ramucirumab, which has the most data, as our next treatment option. So we're going to go back to those initial quiz questions from the very beginning of the talk and see what you think now. Second-line therapy with a PD-1 or PD-L1 inhibitor, the immunotherapy, is not recommended for a patient with which of the following characteristics? Okay, bravo. The majority of you got the right answer, which is EGFR mutations. Patients who have EGFR mutations don't tend to have much of a benefit with immunotherapy. Okay. Which patients in particular benefited from ramucirumab in the Revel study? Patients who had a performance status of 2, patients with squamous cell histology, patients with shorter time to progression after first-line platinum-based therapy, or D, unsure. Okay, and almost 2/3 of you got the right answer, which is a short time to progression after first-line therapy. Based on current recommendations, what would be the most appropriate second-line therapy for a patient who has PD-L1 positive, 55% squamous non-small cell lung cancer who has progressed on first-line immunotherapy? Would you switch to a different immune checkpoint inhibitor? Would you continue the immunotherapy beyond progression? Would you switch to platinum-based chemo? Would you do chemo and immunotherapy, or would you go to docetaxel and ramucirumab? All right, so kind of tied between the two most popular answers being chemo added to the pembrolizumab or using docetaxel and ramucirumab. So frankly, we don't really know what the best next strategy is after somebody progresses on immunotherapy in the first-line setting. That hasn't really been studied in clinical trial. But what we currently are doing is actually using platinum-based chemotherapy. So if a patient progresses on first-line pembrolizumab, then we go back to the chemo that we would have used in the past, carboplatin and cisplatin with a second drug. We don't know yet if adding chemo to the immunotherapy at the time of disease progression would actually benefit the patient, and that's something that should be studied in a clinical trial. Then what would you recommend for a non-squamous lung cancer patient, low PD-L1 expression, who progresses after first-line therapy with chemo and immunotherapy? Would you switch to a different immune checkpoint inhibitor in combination with chemo? Would you re-challenge with platinum chemotherapy with or without angiogenesis inhibition? Would you continue pembrolizumab and switch chemotherapy? Would you do docetaxel and ramucirumab or docetaxel alone? And most of you got, I think, what is the best answer, which would be switching completely to docetaxel and ramucirumab. At this point, we don't have any data that if a patient progresses on one immunotherapy, that another immunotherapy would be any better, or that switching chemotherapy and continuing the immunotherapy would be beneficial. So the summary of the talk from today is that immunotherapy has become a very central part of our management of patients with metastatic lung cancer. We have some biomarkers such as PD-L1 and tumor mutation burden, which may be able to help us identify patients who have the most benefit from immunotherapy. We currently have 3 immunotherapy drugs that can be used in the second-line setting after progression on chemotherapy. Patients who have driver mutations typically don't benefit from immunotherapy. And now in the last year, we've had a move of chemotherapy being combined with immunotherapy in the first type of treatment for patients with metastatic lung cancer. And that's going to impact how we sequence our therapies. At this point, I think that the combination of docetaxel and ramucirumab would be a reasonable option in these patients. And at this point, we don't really know if immunotherapy combinations are going to be better than pembrolizumab monotherapy or immunotherapy and chemotherapy. So thank you so much for your attention and your participation in the questions. I'm happy to take any questions at this point. All right. I guess clear as mud. Great. Thank you so much.